Good morning, everybody. I'm Ashraf Raycliffe, the National Occupational Health and Safety Training Manager at the National Institute for Occupational Health, the NIH. Welcome to the NIH's Zoom online COVID-19 training, and particularly today we're looking at BioRisk Assessment for frontline workers. In many of our previous Zoom sessions, we've indicated the importance of risk assessments, the COVID-19 required new risk assessments. So please, first a quick bit of admin. At the bottom of your screen, there's the chat bubble. Please click the chat bubble and include in the chat bubble your title, name, surname, email address, and please your cell number, because we may want to send out bulk SMSs for future invitations. That same chat bubble at the bottom is going to be the place where you will be adding your questions for today's session, as our series of presenters are going to share with you very critical information around BioRisk assessment for frontline workers. But as part of our welcome, I would like to introduce you to the organizations that's responsible for this, ourselves, particularly the NIH, and the broader context within which we operate within the National Health Laboratory Services. My colleague Glenn will share with us in a moment 2 slides. One slide will be the overall, okay, I think we're going, okay, so I will get back to that slide probably towards the end, just to give you a quick sense of what is required. But the National Institute for Occupational Health, the organization hosting the Zoom session, is part of the National Health Laboratory Services, right? That's the umbrella body of which we are the one specialized institute looking at occupational health. Our sister institute is the NICD, the National Institute for Communicable Diseases, specifically looking at the COVID-19 clinical aspects, laboratory testing, and support for the National Department of Health. So the capacity, as you see on your screen now, of the National Health Laboratory Services, our umbrella body, it is the largest diagnostic pathology service in South Africa. More importantly, you will see that more than 80% of the South African population, given also the disparities within our society, the lab and other related health services is provided by the NHLS, including the NIOH and the NICD, which I'll come to in a moment. Thirdly, we support the National Department of Health. The NHLS also supports all of the provincial departments of health. On the right-hand side top corner, you'll see that the NHLS at the moment has 7,515 employees in various capacities, laboratory support, as well as occupational health and infectious diseases control capacities. The bottom section shows you the 356 laboratories across 260 sites in all 9 provinces. Administered through 6 regional offices of the National Health Laboratory Services. The NHLS has a capacity for diagnostic tests of over 30,000. That's a significant capacity, and it's important for this particular capacity to be maintained and for this resource to be its continuity and its capacity to be guaranteed. Then our sister institute is the NICD, the National Institute for Communicable Diseases, based in Sandringham, where yesterday I think 60 more mobile COVID-19 testing units was launched by the Minister of Health. Is the other sister public health institute that is leading the response within the NHLS on the COVID-19 crisis. Then finally ourselves. Your host today of this COVID-19, one of many that has happened and many more that will happen, the COVID-19 training session with a specific focus on the BioRisk assessment for frontline workers. The NIH we have our specific focus on occupational health with numerous sections from immunology and microbiology. You meet those colleagues today, occupational medicine, occupational hygiene, toxicology, and I can go on with the list up to pathology, significant concentration of expertise that we would need to call upon. That's the NHR list. Glenn, can I just get the next one? So, thanks. For the NIH specifically, now let's pause and give you some emphasis here on the services we provide. And you'll see that around the central circle of occupational health. Teaching and training is the session that you are receiving now, which has interdisciplinary contribution from all of our specialists in the different sections. Knowledge generation through the research, specialized research, as well as the sort of support services that comes from the 3 specialized libraries that is housed by the NIH. One specifically for the NIH, one for the NICT, and one for the National Health Laboratory Services. The other platforms that we deal through is not just the Zoom session, but we have the websites, and there's an important newsletter that all of you must subscribe to called OccuZone. And therefore, we'd like to ask your permission when you share your contact details with us for us to be able to also send you the newsletter. Our advisory services range not just from asbestos hazard, our analytical services deals with organic and inorganic chemistry, and many other services that we provide in the field of occupational health. Many of my colleagues are also involved in academic teaching through the institutions of higher education. Outbreak response is the team that's responsible for these Zoom sessions, headed by our chairperson, our head there, Dr. Tanisha Singh, who you'll meet in a moment, who's also the head of immunology and microbiology. And then the other specialized services that I've indicated. We have our teams going out to do both environmental and personalized monitoring and sampling, also from our occupational hygiene section. The National Institute for Occupational Health therefore bring you this session on BioRisk Assessment for frontline workers. And I have the pleasure to ask Dr. Tanisha Singh to please give you the introduction to this BioRisk Assessment for frontline workers session.
Thank you very much, Ashraf. Glenn, can we get the slides on? Okay, so today we're going to look at frontline workers. And I think the important thing is to define what are frontline workers. And these are people who directly interact with customers or clients, and it is contrasted from back office workers who really meet a customer or a client. And many of our frontline workers are essential workers as well. And based on the pronouncements by the president and the restrictions of lockdown, many frontline workers are still at work today. So I just want to take you back to about a month or two, looking at the statistics we had globally for the month of February. We had 75,000 cases and approximately 2,000 deaths across 25 countries worldwide. And if you fast forward that to yesterday, we see that the number of cases has increased tremendously, and we're sitting on 911,000 cases and 45,000 deaths across 203 countries. And that is an increase of approximately 836,000 cases, 43,000 deaths, and an increase of 178 countries worldwide. So the spread of coronavirus globally is significant, and it's something that we really need to respond to aggressively. And so we're going to be talking about some of the measures regarding BioRisk assessment and control strategies to put in place to control and contain the spread of the virus. Now, when we look at the country's preparedness for a pandemic, there was an assessment that was done to rank countries according to their health security. And the report showed that no country was truly prepared to manage a pandemic such as COVID-19. The Health Security Index measures the state of the health security across 6 categories. The first being the prevention of the emergence or the release of pathogens, the rapid response and mitigation of the spread of an epidemic, the early detection and reporting for epidemics of potential international concern, and robust health system to treat the sick and protect health workers, and an overall risk environment and the country's vulnerability to biological threats like COVID-19, and the commitment to improving national capacity, financing plans, and adhering to global norms. This report showed that 73% of the world's population lives in countries that scored below 50 in the Health Security Index. And that's phenomenal because it means that we are not going to take control as rapidly of the pandemic as we should. The report also found that most countries lack the foundational health system capacities vital for epidemic and pandemic response. If we just take the top 4 countries that has the highest number of cases and deaths, that is the USA, Italy, Spain, and China, and look at their preparedness, we see that the US scored the highest with 83.5, and that was in terms of the epidemiology workforce, their biosecurity and emergency preparedness, as well as their response planning. The next country that scored fairly high, but is 3rd in terms of the number of cases it's reporting, is Spain with 65.9, and South Africa in comparison scored 54.8, and China 48.2. So that gives us a sense of how prepared we are as a country in relation to some of these countries that have better health systems, but have a large number of cases and deaths that they are dealing with currently. So we definitely need to put in place measures that can flatten the curve. Simple precautions of hand washing, social distancing is important, and more important, to stop the spread. We need to look at alternatives and have a strong collective response to control and flatten that curve, and also to maintain it, because whilst we are all in lockdown, when workers come back and things come back to normality, we may see a resurgence of cases again, and so it's important that we take control and maintain our systems going forward. So let's come and look at some of the estimates that have been projected for South Africa. These were some projections that was done by Sakima, and they based it on the infection rate of 29% as at March the 19th. And we see on the graph that by April the 1st, they had projected approximately 4,000 cases for South Africa. Yesterday, the health minister reported 1,380 cases, which is significantly lower than the projected figures, but still very high. And these are figures that are based on laboratory confirmed cases only. There may be more cases that we have not found yet. So it is important that we understand that this is a serious matter, especially when we know our health care system is constrained, we don't have enough doctors and nurses, and we don't have sufficient bed density. So let's look at the figures for the different provinces, and also the increase of figures from a week ago till yesterday. On March the 25th, we had a total of 709 cases, and yesterday the minister reported 1,380 cases. That is an increase of 671 cases in a week. Gauteng is a province that has the highest number of cases. 326 cases was an increase from the previous week, and that number is significant because the increase in the number of cases in Gauteng is equivalent to the number of cases reported in the Western Cape. We see that there was an increase from last week till yesterday in the Western Cape of 143 cases. KZN showed an increase of 95 cases. Free State, 46 cases. And those 4 provinces reported deaths. Some of the deaths were a teacher was affected, a scientist, a priest, and that shows that we don't know whether it was occupationally acquired at this stage, but it does show that there is an impact on the workforce, because we will be losing workers as a result of COVID-19 infections. More important is the unlocated cases that tested positive due to insufficient information provided to the laboratory to activate contact tracing, and these cases are in the community and could potentially be spreading the disease. So we know that the transmission is through droplet transmission as well as direct contact. So when we are talking, when we are coughing, when we are sneezing, we are potentially transmitting the viral particles. Many of them fall onto surfaces and contaminate surfaces, and that's why it is important to maintain a social distance and to clean our surfaces regularly. On average, we know that the incubation period is 5 days, but can extend to 27 days. And so during that period, generally, we know that most people are not infectious, but there are some scientific evidence to show that a small percentage of people that are asymptomatic could still transmit the virus. But on average, most people transmit when they are infectious due to their coughing and sneezing and releasing the viral particles. This picture shows us an important number, and it's called the basic reproductive number, and it is a measure of how many people each sick person will infect on average. We know that measles is the most infectious disease with a reproductive number of 16, and COVID currently sits on 2.5, meaning that for every infected person, 2.5 other people could potentially become infected. Now that seems like it's small, but if we do the math, there is some mathematics behind social distancing, and what we see is if you have a person that is incubating for an average of 5 days, they could potentially infect 2.5 people. If they continue to infect people over a 30-day period, one person could potentially infect 406 people. If you reduce the exposure by at least 50%, then one person could potentially infect 15 people in a 30-day period. So you can see that through social distancing and preventative measures, you can reduce the number of infections significantly. The bottom row shows us if we reduce exposure by at least 75%, then you could, the reproductive number can become much smaller of 0.625, and then in a 30-day period, you could possibly infect 2.5 people. So that shows the importance of social distancing. What I have on the right-hand side of the slide is a case from South Korea. Many of you may be familiar with the case. It's called Patient 31. Patient 31 was responsible for 80% of infections in South Korea. And that shows how important social distancing is. She had no symptoms, looked healthy, met an accident, went into a hospital. Then subsequently she went to 2 church gatherings where there was a significant number of people, and then later she visited a hotel restaurant, a buffet style restaurant. In that process, she had infected 1,160 people. This is a significant number, and it's something that we need to take note of from a social distancing point of view. And that's why the lockdown for us is so important, so that we bring down the number of cases that we could potentially infect. So let's look at the survival of coronavirus in the environment. We know that the virus has a fragile outer membrane and it is less stable in the environment. But there has been studies that have shown that the virus can survive on inanimate surfaces from anything between 12 hours to approximately 9 days. This survival time depends on the environmental conditions, including the pH of the substance it's settling on, the inoculum size, the dryness in the environment, that is the level of humidity, the temperature, and the type of surface that it lands on. There are different types of surface materials, and each material comes with a different survival time period. If you look at copper is not on the picture, but it is the one material that has the shortest period in terms of the survival for the coronavirus, for envelope viruses. Aluminium, the envelope viruses can survive anything between 2 to 8 hours. If you look at more porous materials like wood and paper, it can go up between 4 to 5 days, and on surgical gloves, up to 8 hours. And that is why it's important that we understand when to use surgical gloves, and that surgical gloves can be a source of contamination, and my colleagues with me today is going to talk to you about that. We also know that the exposure to disinfectants is one way to reduce survival time, and simple disinfectants is very effective for envelope viruses, like 70% alcohol, bleach, quaternium ammonium compound products, as well as products containing glutaraldehyde. If you visit the EPA website, there is a whole list of disinfectants that can be used for envelope viruses. So this is a illustration of the impact of infections. We know based on the infection rate in other countries, on average, 60% of the population can be infected, and this depends on, on the type of preventative measures at country level and at individual level that we put in place. And all of that 60%, 80% on average present with mild symptoms, and that resolves itself. 50% presents with severe cases. On average, 5% will result in critical cases, and 2.3% may succumb to the disease. In terms of the symptoms to look out for, the common ones that most people present with is sore throat, cough, headache, high fever, and shortness of breath. And having these symptoms does not mean that you have the COVID disease. You have to meet the case definition to be able for testing to happen. And once you have those symptoms, you need to also look at whether within the prior 14 days from the onset of symptoms, whether you were in contact, face-to-face contact, or working in a closed environment with an individual that was positive for COVID, whether you were admitted with a severe pneumonia of unknown etiology, whether you were a healthcare worker or other person providing care while not wearing the recommended PPE, or if you have visited a health facility where a COVID-19 case was being treated. There are the two definitions that should be met. These are less so now with the lockdown in South Africa, but still we have many people that are traveling, and if you have traveled to an area where there is local transmission and you have symptoms, then you meet the case definition. So what happens then if you have symptoms and you meet the case definition? There may be some other etiology at play, and therefore you should first look at what are the other possibilities. Maybe it's flu-like symptoms, maybe it's allergy-related, and if that is negative, then it's fine. If you rule out all other etiologies, then you need to contact the NICD hotline. In that case, you would test SARS-CoV-2, which is the name for the coronavirus. Testing would be indicated, and you would need to follow infection prevention and control measures. From a worker perspective, I'm just going to go through a few points that would be expected of you during that period. If you presented and meet the case definition, you would be expected to provide information for the forms that has to be submitted to the NICD, including a contact list. A sample would be collected from you that will be sent to the NICD, but now also to private laboratories. We also have the mobile laboratories and other labs within the NHLS where the specimens can be sent to. If you test positive, this will be notified because it's a notifiable medical condition. And let's look at the steps that will follow once you submit your specimens. If the specimen comes back negative, you will maybe be reassessed to see whether subsequently you develop symptoms. If not, it's all fine. If you do develop symptoms, then you will follow the same routine again, going through sample collection and retesting. If your test comes back positive, depending on the severity of symptoms, if the symptoms are mild, you will be self-isolated. If they're severe, you'll be admitted to hospital. Sequential testing will be done. If negative, you will be discharged. If it is positive, then retesting will be done until the test comes back negative. During that time, it is important to do the contact tracing, and there are teams that will be deployed to assist with the contact tracing, and you will be monitored for the 14 days to ensure that those individuals don't present with symptoms. There are two types of contacts. You get a casual contact, and the contacts need to avoid all essential contacts. They must be self-monitored, and if they are asymptomatic during the 14-day period, the monitoring is stopped. If they are symptomatic, then they will be tested, and the same routine will follow. For close contacts, they need to be quarantined, and the NICD will submit a letter, and they again will be monitored. And the monitoring includes a register of symptoms as well as your temperature. And if you're asymptomatic, then the monitoring is stopped. If symptoms develop during that time, then you will be sent for testing. So how does the testing happen? Currently, persons under investigation are tested, and before the test happens, the doctors need to be contacted first. And at the NHLS, the tests are free. These may, in the private sector, you need to contact the laboratory to determine what the cost is, and then they will give you specific guidance on the sample collection and transportation. Those are the website in terms of the diagnosis process, as well as the contact number to call should you need further information on that process. It is important to know that the test will only be positive if a person has active disease, and this varies between mild and severe symptoms. The test does not identify persons who are incubating the infection, and the turnaround time varies between different labs. On average, it's anything between 48 hours to 72 hours after reaching the laboratory. And also important to know, asymptomatic persons are not tested currently, and the testing is not done to determine exposure or to give a clearance so that you need to go back to work. So those are important things. The picture on the right-hand side shows how the nasal swab is done, and the swab is put into the nasal cavity right to the back. It is a little uncomfortable, so I wouldn't want that to be done to me, and therefore I would encourage everyone to practice their hand washing and their social distancing. So now let's look at the workplace and COVID-19 in the workplace. How does COVID-19 come into the workspace? Well, there's two ways it can come into the workspace. The first is through community acquired. As a worker, you are in your communities and doing your social activities. You may contract the disease and unintentionally come into the workspace and then spread it within the work area, or it may be workplace acquired, and due to the type of activities you conduct, you may be exposed at work. Which workplaces are affected? Any workplace is affected. These are just some examples on the screen. Healthcare facilities, South African police services, factories, retail workers, emergency medical services. Any workspace with high population density is particularly at risk. but that does not rule out areas where there is low density. So it is important to assess what is the risk in different workplaces. Which workers are affected? Any worker may be affected. It can range from the CEO right through to your entry point where the security officers are, our cleaners may be affected. So it's important to understand what are the different activities and how to eliminate exposure. We also, from a work perspective, need to consider people on our work premises, our visitors, our contract workers as well that come into the facility who could be potentially at risk. And then we need to take into consideration the high-risk occupations. These are also only examples: healthcare workers, lab workers, ward workers, border control workers, and frontline workers in general could potentially be at risk. Then we have workers that we need to take into consideration, and these are the risk workers, at-risk workers. And these are workers that have immunocompromised, and this could include people with chronic lung diseases, including TB, asthma, COPD, autoimmune diseases of any kind, workers who have chronic kidney disease, cancer, diabetes, and workers with HIV and have a low CD4 count are potentially at risk. So we need to conduct a risk assessment to understand the different complexities within our workspaces and also to ensure that it is job specific. Now we are guided by a number of legislations and regulations that pertains to occupational health and safety in the workplace, and of particular importance are the ones that are listed on the screen, and the hazardous biological agents regulation is very important, and it looks at the risk to both the worker, the visitors, but also looks at the roles and responsibilities of the employer and the employees. And I encourage everyone, if you don't have the regulation already, to download the regulation and familiarize yourself with it. There are a number of policies, directives, circulars, standard operating procedures that have been released by various bodies, and depending on the work environment that you find yourself in, it would be important to familiarize yourself with these documents. The NRH has a resource tab on their website where they have put a number of documents, but it is not a complete list, so you are still encouraged to find what is relevant to your occupation. So what are the minimum expectations of the employer? I think from the first thing is to have management, top management commitment to comply with the legislation overall, then to provide a safe and healthy workspace, ensure that we have an occupational health and safety policy, there is direction in terms of risk management, incident management, and risk communication within the workplace, to understand the financial implications and how to buffer that during the outbreak and the lockdown, to ensure that we have HR support, to give to workers, not to victimize workers that present with symptoms, and just to have an enabling environment so that workers can come forward and report should they be presenting with symptoms. And then to have a business continuity plan. When we're dealing with the workplace, there are three major pillars to look at. The first is the virus itself, then the environment and the host, and my colleagues are going to talk in detail about these. But just in terms of the anticipation of risk in the workplace, I've got four steps that I believe that all of us should be following. The first is to relax, not to panic, because when we panic, we don't think rationally. So rewind, go back to what you have in place in your work environment. Every workspace, whether you are self-employed or whether you have a big operation, you should by now have done a risk assessment. Review the risk assessment and then reinforce the control measures that you've implemented and make sure that you are maintaining those control measures. Now we know there are different types of workers within the work environment, and every worker has a different risk exposure profile based on the specific job that they conduct. So it's important that the risk assessment that is done is aligned to the function that the worker is doing. And also to consider all other hazards when you are conducting your risk assessment. Now, when we do the risk assessment, there are many different templates available. Some have, there are two examples that I'm presenting to you, a semi-quantitative method, or you can do a qualitative method. It's really up to you and the organization. But essentially, what you are looking for is what is the consequence, the severity, whether it is very severe, whether it's moderate or negligible, how frequent does the hazard occur, and what is the likelihood of the disease occurring? Is it unlikely, is it possible, or likely? And when assigning priority to the risk based on your risk matrix, to also consider other factors like the urgency and the feasibility of control measures, the delivery, the installation time, and training, which may be problematic for some of the measures you put in place, particularly now in lockdown, as many of the workplaces are closed. So these are all practical things that one needs to take into consideration. In terms of the mitigation of risk within the workplace, we can use a tiered approach, looking at primary prevention, that is the business continuity and pandemic preparedness, also to minimize the risk of transmission by implementing a hierarchy of controls, education and training, and important risk communication. Then look at secondary prevention in terms of identifying persons at risk early and responding appropriately. The third layer is to respond appropriately to a case of COVID amongst your staff, to do the incident investigation and the contact tracing, and if it is occupationally acquired, or even if you think it is, to make sure that you submit to the Compensation Commission. And then also to look at rehabilitation of workers that are severely ill or critically ill. When they come back, they would need to be rehabilitated, and this needs to be considered. So in terms of the hierarchy of controls, there are 5 different pillars that one takes into consideration. The first being elimination, where we want to eliminate the hazard. And my colleague is going to do a practical example of what are the possibilities to consider. Sometimes it may not be practical or impractical for unknown exposure. It may only be practical for intentional use, like in a laboratory setting, where you can eliminate the agent, but in most cases it's very difficult because you're not sure who is carrying the virus. And if elimination is not practical, you look at substitution to replace the infectious agent. If that is not practical, then look at engineering controls to reduce the exposure without relying on worker behavior. Currently, during lockdown, this may be challenging, and also in outbreak response, it is challenging in terms of the time it takes to implement some of these engineering controls. But there are very innovative and practical ways that you can engineer the problem out. And so with disruption comes innovation, and this is what workplaces should be encouraged to do. When you're engineering, you can look at the building, you can look at various devices, as well as the environment. And if this is not comprehensive, then you need to also look at your enhancing your administrative controls, reviewing your policies and your procedures, also look at your health protection program you have in place, and also review your training and redo training where necessary. If not sufficient, then, and also sometimes it's not sufficient because we have challenges with behavior, these controls are effective when we have the right attitude in the workplace, and we sometimes have challenges with adherence to some of the control measures that's put in place. And then the last thing we should be looking at is PPE, but my colleagues are going to talk to you about the challenges of PPE and when PPE becomes important in an outbreak situation like we're dealing with. So the occupational health practices to review really simple things, limit your gatherings. Although we have the lockdown now, we still have people going into retail stores, etc. And there is a number, it was less than 100, it is now less than 50, but maintain, even with that smaller number, maintain social distancing, reduce waiting times in areas, review your specific procedures in terms of access control, aerosol generating procedures, etc. And then insist on people that are symptomatic to stay away, especially during the period where we're providing essential services. In terms of protective equipment, we know that PPE is an effective measure within a complete package of mitigation and control strategies, and then the usage should be informed through the risk assessment, which the colleagues are going to take you through, and then to ensure that within the workplace, if PPE is required, that it is available and the appropriate PPE is available to workers. And used PPE should be considered contaminated and discarded accordingly. It is not recommended for asymptomatic individuals, although we've been hearing some talk about the WHO reviewing their position on who should be wearing masks. This is still to be confirmed, and so for now, this is what the recommendation is. So now that you have your whole basket of controls, it's important to know which to use, when to use, and how to use it. And then to stick to the general precautions as a reminder to everyone, this is out in the public domain, but washing your hands, sanitizing when water is not available, cleaning your surfaces, staying at home if you're sick, cover your mouth if you're coughing, don't touch your mucosal surfaces, don't touch people who are who may be sick or confirmed to have the virus, and then just to maintain a general health. Those with chronic diseases, to control their chronic diseases. And we know that currently there are no vaccines for COVID-19. However, it is advisable to take a flu vaccine to prevent influenza and unnecessary testing of COVID-19. And then for those who are traveling, to make sure that it is, that you do maintain a risk register and that it is being updated within the work environment. So for me, the take-home messages, people are the ones who are carrying the virus, so we are the ones that can stop the virus. We need to adhere to the President's pronouncements and the lockdown requirements from each individual. We need to do the right thing and lead by example to keep our economy going and to develop and comply with workplace policies and procedures. And like I said, disruption leads to innovation. We need to think creatively, use simple innovations that are cost-effective, and this can actually go a long way in terms of reducing the spread of the virus. Also important is that all risk is not the same, and hence controls cannot be a one-size-fits-all. We need to conduct a job-specific risk assessment. And with that, I'd like to thank you.
Thank you very much, Tanusha. That was Dr. Tanusha Singh dealing with a very comprehensive introduction on the current COVID-19 crisis we face within the context of a national disaster declared by President Ramaphosa, as well as the 21 days lockdown period. So I think the session is coming to you critically at a time during the lockdown, because we're not dealing with workplace preparedness and prevention around this particular matter, but also around lockdown preparedness and the return to work period thereafter. I'm going to ask my colleague Glenn just to prepare the slideshow for our next presenter, and that's Ms. Monica Matuka. She will be presenting on principles of BioRisk Assessment. And a quick reminder whilst we're setting up the chat bubble at the bottom, please add title, name, surname, email address, and cell phone numbers preferably for future bulk SMSs as well. So we can have a register of all of those who are online. Glenn, what's our current number? 505. 505. That means this is the second session that we have reached the original 500 mark, but I think our capacity has been increased. So at this point, on principles of BioRisk Assessment, Monica Matuka.
Thank you, Ashraf. Good morning, everyone. Today I'm going to present to you BioRisk Assessment for COVID-19 for frontline workers. So this will be the first session, and after a few speakers, I will follow through with the BioRisk Assessment tool. So, workplace BioRisk Assessment is defined as the process of determining the risk associated with exposure to a particular biological hazard and evaluating the existing controls and deciding if the risk is acceptable or not, with the aim of protecting the health of the worker as well as that of the public, and to prevent or reduce exposure in any workplace. This will also inform what mitigation strategies to be put in place in different workplaces. Biological risk is the chance that the biological material can cause harm to the health and safety of a person. And there are different types of hazardous biological agents. Those include bacteria and the viruses, which is our focus today, fungi, parasites, allergens, as well as the microbial bioproducts that are produced by different microorganisms. And the proximate sources can either be people or human, or it can be the environment that we work in, as well as plants and animals. For today, when focusing on workplaces, the main sources will be your people and the environment you work in when it's contaminated. So hazardous biological agents are classified into 4 groups. So the main group that is our focus today for coronavirus, because we know that it can cause severe human disease and it can be a serious hazard to the exposed worker, and it can spread to community. And we all know there is no treatment available at the moment. So we will classify it as a group 4 until there has been a treatment found. Then it will probably downgrade to a group 3, which also can cause severe human disease. It's a serious hazard to exposed worker, can spread to community. But for group 3, there is effective treatment available. So in order to conduct BioRisk assessment, one needs to know the difference between the 2 terms. You need to know what is the hazard. It is defined as anything that can cause harm to the health and safety of a person, whereas the risk is the chance that a person will be harmed by this particular hazard. It can either be high risk, medium risk, or low risk. So it's important to differentiate between these 2 terms for the effectiveness of biorisk management. So why is biorisk assessment necessary or important? Firstly, it is a legal requirement under the Occupational Health and Safety Act. We get the hazardous biological agent, which requires the employer to protect their employees and make sure that they have a safe working environment. So the other reason is that it's the key for prevention strategy. So while you're doing your policies on infection prevention and control strategies, this is an important thing to do and to include in that policy. And then it's mainly to determine the risks associated with the biological agent coronavirus in this instance. And then risk assessment must be done at the beginning as well as continuously. So the regulation recommends that it be done every 2 years. However, it should also be done when there is any change in the environment, when there is any change of equipment or building. Like now, because of the emerging pathogen, which is the coronavirus, risk assessment needs to be relooked at. And it must be done in consultation with Health and Safety Committee, and the records must be kept for 40 years as recommended by the hazardous biological agent regulation. So there are 4 main pillars of risk assessment. The first step is to identify the hazards. So there you look at the different occupations, and within occupations also you can find out that people does different activities. So it must be done by activity or a process that's taking place in the workplace. And then the second step, then you decide who will be affected. So you look at your workers, you look at different positions or tasks, Then you identify those people and you will record who can be harmed and how they can be harmed based on the processes that they do or the work that they do. Then the third step, you evaluate the risk. That's checking the likelihood that harm may occur and the consequence from being exposed to that, whether there's severe or there will be any loss of human life, and the number of workers exposed at the time of work or at the time of risk assessment. And then determine what existing controls are in place and if they are adequate or if you need to add on extra measures in controlling the risks. And lastly, BioRisk assessment must be recorded, because if it is not recorded, it's not done, and then an action plan needs to be taken into consideration of when will this mitigation strategies be put in place and who should be doing this and when is the deadline. That should also be recorded. And the risk assessment must also be reviewed periodically, as I've mentioned, when there is any change of some activity or equipment or anything in the workplace. So basically, the BioRisk assessment approaches depend on the nature of the workplace. What are your sources where you're working, or indirect or direct sources? And then the type of processes at your work. So for various workplaces, you know your workplace better, you know the activities. So while listening to this or while doing a risk assessment, determine what activities are there and associate them or link them to the risk assessment tool and see how you can best fit it. The task performed at the time of conducting assessment is also critical. Risk assessment is not done when a person is sitting in the office and just thinking, okay, this person do this person do this, so I can do this. Yes, it may be costing in your mind, but actually the best way to do it is to go physically and observe the worker doing the tasks and record what you see, and also ask the questions, because it's important. The employee might provide you with all the necessary information that you will need. You might not know everything that they do, and also on that particular day when you're doing risk assessment, they might be skipping a certain step which they usually do in their normal processes. So they will be able to tell you if they are not doing it at that time. And then lastly, the technical complexity of workplaces. As we all know, all workplaces differ and they have different processes within their environment. So there are common mistakes that are made when doing BioRisk assessment. It is usually seen as a once-off process, but actually risk assessment is an ongoing process. Sometimes it's not even documented, or people take it as a tick box exercise. Like I said, a person will just sit in the office and just tick because they know that there will be an audit or an inspection, so they want to have documents ready in place, and that shouldn't be the case. It must be done properly, because the important aim or goal is to make sure we protect our workers. Sometimes workers are also not involved, so it's recommended that when you do risk assessment, you involve the worker and encourage them to also report if they see there are any additional risks that have probably been missed, so they can share the information, and that can be included in the BioRisk assessment report. And hazardous biological agent risk sometimes is not assessed fully because people have little knowledge on when it comes to biological agents. But then they can ask assistance from those with expertise or those who have the background on what to look for. And the preventive hierarchy, as mentioned by the previous speaker, is critical, because that is going to help you when you need to mitigate, because that will guide you on what control measures to put in place. And long-term risks are sometimes underestimated or denied. So the challenges with doing the risk assessment, in particular for the coronavirus. Currently, there's uncertainties about the virus. As you know, it's all evolving now. There is no like certainty of actually what is this virus do. But we have some information. We can work on the current information that we have on exposure as well as on how the virus behave. And there's also currently lack of treatment as a control measure. So other alternative measures like supportive care for those who are affected can be put into place, your self-isolation and so on. And then I've spoken about the classification of the virus, which is not for sure for now, but based on the regulation and the definition of the different classes of HBAs, then for now we classify it as class 4 because there is no treatment available. The other challenge is shortage of resources for mitigation as well, because there's lack of respirators, lack of masks, but people are trying, or workplaces are trying as much as they can to acquire those resources and make sure they are used appropriately. And then the fit testing, which my colleague after me is going to talk about, it's also a challenge because at the moment, because of the rush, because of the fear, people are just buying masks or respirators, and they're just wearing the respirators without fitting. How do we know for sure that it's protecting the worker? How do we know for sure that it's fitting when fit testing is not done? Individual susceptibility also. People differ and they respond differently from exposure to hazardous biological agent. And you get those that are immunocompromised as well with underlying conditions, those that are more vulnerable than the normal healthy workers. So emerging pathogens are a challenge, and this coronavirus is one of the emerging pathogens which was similar to the SARS and the MERS that happened previously. So people need to always be alert and be informed as it's evolving. The more information we get, the more update we get, and we know what to do on mitigating the risk or preventing exposure of the worker. And then also to emphasize that risk assessment should be updated when required. So things to consider when conducting BioRisk assessment. We must remember that microorganisms are everywhere and they are invisible. So there is no way you can avoid them. And then hazardous biological agents cannot be eliminated as they are there. So the best thing to do is to minimize the risk at each point of chain of infection, which is from your source. You can prevent it, break the chain there, or break the chain at your host, or even at your environment. But the best way is to start at your source first, because you don't want it to go any further. Checklist for assessing the risk of biological hazard is not standard, so it will differ by sector. Whatever tool you have now, you can still apply. Just make sure that it covers basically all the necessary information that is needed about the hazard, about the risk, who in your workplace will be affected, and what health effects. We already know now the health effects for the coronavirus, what they are. And then also look at your high-risk groups in your workplace. That information will be found with the occupational health practitioners or professionals. So when you do risk assessment, because it's not always the case that the person who does the assessment will have access to information, because it's confidential information that remains with the medical practitioner. But it's important that the person that does the risk assessment must share the report with the org health professional or practitioner, so that they are able to see which group to focus on, or which workers to focus on that can be more at risk. And after doing risk assessment, it's important that you communicate the risk so that everybody knows what's happening in their workplace, what hazards they are exposed to, what risks and health effects they can be prone to. So include your workers in this communication, include management as well, as they are the ones who put together policies in place for different workplaces. And they will also be able to allocate resources where there's a need to probably, for example, install any device or to buy your respirators and whatever mitigation strategies you need that requires a budget. So involve management as well. Engage all committees in your workplaces that has to do with health and safety. If you have the BioRisk Management Committee or the Outbreak Response Task Team at the moment, they should be actively involved. Your occupational health practitioners or professionals, your health and safety people has to be involved, as well as your infection and prevention control committees must be involved in this process, or the discussions for that matter. And then where there is gaps or lack of expertise or uncertainties, you can still contact your external advisors who will be able to help you or advise you on closing those gaps or on filling up that information that's lacking. So there are certain limitations when doing BioRisk assessment. The assessment is not quantitative, simply because there are no occupational exposure limits for biological agents, as compared to chemicals where you get a certain figure to say, this is the limit, you shouldn't reach this limit. With biological agents, it's different. And you get a whole lot of diversity of microorganisms. So it won't only be the coronavirus in your environment, there'll be other biological agents. So when doing this assessment, focusing on coronavirus, think of other biological agents as well. And importantly, microorganisms can replicate at any time. So whatever you find at that moment, when the environmental conditions are conducive, high temperatures, high humidity, microorganisms can replicate or reproduce. Some can mutate, like the coronavirus at the moment, which makes it more difficult because it will keep changing. And then lastly, the susceptibility, variability between different individuals. People respond differently to exposure or to microorganisms. Therefore, that makes it very complex. So it doesn't guarantee non-exposure or absence of all risks, because you're doing it looking at observing the task at the moment and on a particular day, which may differ with other days. And unknown and uncharacterized biological agents are also a limitation or a challenge, because like now, coronavirus currently, like I mentioned, it's not classified whether it's a group 3 or 4, but we base it on the current knowledge that we have about the virus. People can make errors as well while working, or they can ignore, although they have information in place or procedures in place, they may ignore what is in place, and that can lead to incidences. So we must try hard to avoid such. And it also depends on availability of resources. As mentioned, involve management so that you are better off prepared in order to put control measures in place. And there's lack of competent staff or expertise to conduct BioRisk assessment. So this is another limitation, but as I've said, you can involve other people as well, or your external advisors. So just to mention a few like mitigation strategies that's usually now like practice. I just want to highlight that for contact, gloves must be used properly So the donning and doffing of gloves must be done properly by the workers. But my colleague Taban is gonna do the demonstration on how to don and doff gloves, and as well as when we look at this picture, it's a police officer wearing gloves. Based on the current activity that they are doing, the question is it necessary for them to put on gloves? So the other concern is, as mentioned by the previous speaker, Tanusha, the gloves can harbor microorganisms for almost like 8 hours. So the question is, when they are having gloves and they are touching different cars, how many cars are passing on that route? You're touching one car and they probably don't have extra pair of gloves, because we also need to consider using resource wisely. So she will be touching the one car and moving to another car and to another car. That may pose a risk to the public as well as to other people like the co-workers as well. So we must be cautious on which PPE we use for which activity. Same as respirators, it must be provided to the right people, but Jeanette is going to talk in detail about this. But the important thing here to highlight is that it must be worn properly, and then a seal check must be done so that to ensure that the worker is protected. If you look at the picture at the bottom, it's one of the pictures I took from TV last night. It's someone wearing a respirator. Is this respirator worn properly? And is this respirator fitting? Judging from how it's sitting, I'm not sure, but those are the points to consider when you do respirators. So in conclusion, risk assessment is part of everyday life. So where you work, as you're doing your work, as you're moving around, you're doing risk assessment. So just keep it simple so that every worker must understand what they need to do, what their hazard is. Don't complicate it with complex tools, because then people will be lazy to look at it and they won't comply. And ensure that all employees understand it and what is required of them, as all employees also have an obligation the same way as the employer has an obligation to provide a safe working environment. Employees must also play their part, and then you just say what you do in your action plan, and you do what you say you're going to do within a specific deadline. Thank you.
And that was my colleague, Ms. Onika Matuka, dealing with principles of BioRisk Assessment. Thank you very much, Onika. Our next presenter, whilst my colleague Glenn is just getting the slides ready, would be Ms. Jeanette Mangani. She's the head of our occupational hygiene section here at the National Institute for Occupational Health. A quick reminder whilst we're setting up, please, the chat bubble at the bottom of your screen is where you need to add your title, name, surname, email address, and preferably a cell phone number, because we may want to send out bulk SMS notices for future communication. And if you've got any questions, please type those questions in that very same chat bubble. I now want to hasten to hand over to my colleague Jeanette on PPE use and respirator fit testing. Thank you, Jeanette.
Thank you very much, Ashka, for the introduction. And I also want to extend my appreciation to my two colleagues who presented on the first two presentations. You decided to lay such a great foundation for me to continue with this topic. So I will just go straight to the PPE. And I just want to mention to everyone who have joined that there are so many questions which are really coming into our institution in relation to the use of PPE. Some of things we'll be able to answer based on available information, but some of the questions is because of the nature of the situation, which is kind of evolving. And as it evolves, we're learning and there's new information coming, weather guidelines, media, and so forth. So Yes, Tanusha spoke in details about the hierarchy of control. So I just wanted to really highlight the reason where this topic is floating perfectly in under the hierarchy of this traditional hierarchy of control. As you can see that in this one, which I think when we look at corona, although it's more relevant to TB infection control, when we look at the behavior of corona, it's more like a biohazard. And we believe that as much as we like not to use PPE or we use less of PPE, we seem to be using more of PPE because they seem to be practical because of the nature of the hazard. Then I know Tanusha spoke about different ways of eliminating engineering and so forth. It seems to me that with corona, we don't have much control over elimination, but we do have in substitution. But we do have control over other means, which start from engineering and more of admin and the use of personal protective equipment. Hence, it was important to introduce this topic so that we talk about what is affecting all of us as we are all worried. How do we really overcome the issue of PPE use in relation to COVID-19? So as Tanusha mentioned, that there are so many agencies, WHO and others, who are now rethinking of how to implement PPE use, who should wear PPE. We also heard on the media, even like in a public setup where everyone was wearing maybe gloves and PPE. There are also a lot of things which are changing, who should wear, who shouldn't wear. So it's same applicable in a workplace, because as the situation changes, evolves, it requires risk assessment, new guidelines, and what has been given previously in the past 2 weeks may not be applicable now. So I seem to think that it's work in progress. But for now, I just want to make reference to my talk under the guideline which was given by WHO on rational use of personal protective equipment. So they have mentioned some of the examples of occupations, and they also recommended types of PPE which should be used. For example, here, healthcare workers who are in direct contact with COVID-19 patients are expected to wear medical masks, gloves, and etc. And as you can see, under visitors, which it was not common before COVID for a visitor to walk in a workplace, be issued with a medical mask, gown or gloves and so forth. So as you can see now that there is a new hazard which requires specific PPE. So I just want to talk about, in general, how do workplaces, how do we really suggest that workplaces decide on which PPE that need to be used? So Onika spoke about BioRisk Assessment. And some of you are wondering that we've been doing a lot of risk assessment. We haven't done BioRisk Assessment. There's nothing different. It's the same thing. If you have done your normal risk assessment, your routine risk assessment, the fact that now we are talking about a biohazard. So we are being specific here that you are doing a BioRisk Assessment, but you don't have to be worried. Those industries or workplaces who have been doing risk assessment, what you need to do now is to review your risk assessment and include the new hazards. So in other words, you are not really taking away all the risk and hazard that you have identified in your previous risk assessment. Now you're reviewing it to make it relevant and current to the situation at hand. So when you want to use PPE, it should be informed by the outcome of the risk assessment. Then if you don't have the risk assessment or haven't done it, it's possible that to make reference to your activities, job occupation, and align it with what is recommended out there. For example, the guideline that I've showed you. If the activities are similar to what your workplaces are doing, then you can apply those guidelines and you adopt it. They become your internal policies and you use it to inform your PPE. So if you have joined today to really get a specific answer from us, that what PPE should I use for these people, I may not be able to give that answer because it's based on your workplace activities, job activities. So we're doing specific risk assessment now that will determine who should wear what in terms of the personal protective equipment. So other important considerations, they include factors like PPE should not be used in isolation. So we have seen that, there are challenges in terms of the PPE. They can be contaminated if you use them longer and you're not changing them. And the virus can remain on those PPE, like for example, in terms of the gloves, Weibo is telling us that the virus can survive up to 8 hours on those gloves. So it's important that as we use PPEs, we should try to work hard to implement other controls like engineering where possible. Then with the coronavirus, we are also advised to wash our hands often. So there are other means, distancing and so forth. So it is possible. So you need to apply what is relevant to your activities and what is feasible and practical in case of a workplace processes. We know that PPE are less desirable, but in practice, these are the most commonly used control measures. And in this case of COVID, we cannot do away with those. We will always use PPE, but in combination with other means of control measures. And hence, I'm saying in my follow-up statement that they are unavoidable during emergency situation, because this is a situation which we didn't prepare for that. So if it hits us, it means that we'll start with the PPE while we implement other controls. So we also need to consider selecting appropriate PPE in relation to the hazard and also the route of transmission. So in relation to COVID, if you suspect that you're going to be touching contaminated surfaces, that's why you need gloves as well. If you're going to be dealing with patients, performing procedures, that's why the gowns are there. You have to wear safety goggles. You have to wear your respirator instead of your mask. So it has to be informed about what activities, and you're covering all routes of transmission to prevent infection. Another question that comes often here is, now there are new suppliers, and as we are struggling with shortages of supply, how do we make sure that those products which are new on the market, should we use them or not? Also, is one of the questions that I may not be able to answer specifically, but you need to know that each and every product should meet the design standard and performance specifications. So you need to make sure that you have some form of documentation to make sure that it really gives you confidence that you're gonna, whatever that you're gonna roll out in your workplace, you have confidence that it's gonna fulfill the purpose that is desired from those products. And with COVID, especially people in a front line who can wear full gear, which include all necessary healthcare PPE, you must make sure that all PPE are compatible with others, so that if you wear another, it does not compromise the effectiveness of another equipment. That includes proper donning and doffing and the proper sequencing of donning and doffing. So by doing that, you make sure that what needs to come first is not going to affect the one that will follow the first PPE that has been worn. Onika spoke about those who are required to use respirators. They may think of implementing field testing. So now the situation is a pandemic situation. There may not be time to do that. And there are those people who have been proactive. Field testing is not a new concept to them. They know what size and what style fits them. So those who are not there yet, we do understand, but you need to be sensitized that you need to be careful that whatever respirator that you're going to use is not the one that will compromise your protection. So I will talk about different sizes, but maybe while I'm here, I can tell you that if you haven't done field testing, there are different sizes of respirator, especially for N95 filtering face respirator. It comes in 2 sizes. The FFP2 unfortunately comes in 1 size. So there is a thumbs up rule that you can check, that if you put a respirator and if you feel like it's comfortable, then the chances are it's not fitting you perfectly, because we are all aware that the air will usually take the least resistant routes. It means you breathe in from the sides. So the respirator that seems to be very tight and makes it so uncomfortable, it is likely that that respirator fits you. But that you cannot really replace fit testing and by doing those physical checks. So I'm saying that in the absence of fit testing methods, then you can try and see how you can compensate to assurity in terms of the sizes and the style that you are issue to people. Information and training is very important, because if you don't train people in terms of the PPE, the chances are they may not use them the way they're supposed to use them, and that will defeat the purpose of obtaining full effectiveness from the use of personal protective equipment. We also need to talk about the limitations, because we cannot rely to respirators or other PPEs fully, because we know that, like with any other control measures, they have their own shortcomings. For example, I can give the difference between FFP2 and N95. I mean, they are equivalent. And the other one filters 94% particles and the other one 95. You can see that they don't filter particles 100%. So by its design, the respirator does not give full protection. So we need to eliminate those shortcomings by making sure that we choose the right size and the right type, so that whatever that we need to achieve from that product, we get it fully by eliminating those factors, individual factors. Then the concept of proper care, maintenance, and disposal is very important. We do receive questions that how do we dispose PPE now? It seems those who are working not in a healthcare industry, they think there should be a separate PPE, not necessarily PPE which are used in a healthcare. But because now we're dealing with a biohazard, which is not choosing healthcare workplace only, it means that the PPE which are dealing with biohazard, whether in a chemical industry where the patient and all, it has to be disposed as a biohazard waste, because we are dealing with COVID-19. So the issue of supply, yes, we are very much aware that there's shortage of stock. Hence, we are advised to minimize unnecessary use. We have tried to check how do we really get to know the new suppliers, local suppliers in the country. So now there is a Department of Small Business Development. Then I've also given you the name of the person who they are busy now. They are working on a database to include those ones, because we may be having shortages and they may be sitting with products which can be used. So I managed to obtain this information today that they are currently adding new suppliers which can assist during the shortages of stock. In addition to that, we have the normal one, which is the South African Protective Equipment Marketing Association. Those ones, they have the members, which I believe in my understanding, we may be using already. And with them, they have their own local distributors who, in case they don't have, they can check some of the stock with them and confirm what is it that they can be able to assist you. So by giving you this information, we want you to check where you can get what you're looking for. Maybe other new suppliers that will be in a position to assist. So in terms of the new products, we're also being asked if we can confirm whether the products are legit or not. Unfortunately, at the NIOH, we are not having the expertise to do that. But we advise you that you need to look at the documentation to confirm performance requirements, specification, and you can also check yourself the standard of approval that has been used. And we believe that if you use service providers who are loaded either by SAPIMA or Department of Small Business Development, they have been checked already, but that does not prevent you from verifying if you are of any doubt if the product that hit your place you think or it looks like it may not be a product which it has been approved. You can also confirm by taking the product marking when you compare to the ones that you're currently using, and you check there. They can also show the standards that has been used to approve the product and so forth. So in terms of the masks and respirators, we do have 2 standards, which is 1866 Part 1 for medical masks and 1866 Part 2 for medical respirator. You can check some of the properties or the characteristics of masks or respirators so that you can confirm whatever you get in terms of the new product is in line with the purpose that you require for your needs. We also need to familiarize ourselves with South African homologation processes in terms of the FFP2 and enhanced with the National Regulator for Compulsory Specification. So ProTechnique, on the other hand, if it's a respirator which is FFP2 and European certified, they can verify if you are in doubt of whatever you're getting. So as we try to optimize the supply, there is a concept of respirator release. Some of us know that manufacturers, they write in their package or in their box that is single use only, but we do understand the situation now. So because of the situation with COVID, how do we optimize the supply? So what we're recommending, we are saying that the risk assessment need to really also propose means and ways that will prevent contamination of PPE during multiple donning, extended use, and also storage. So I also want to clarify, multiple donning is when you are putting your PPE, you remove them, you have a break and you put them on again, take off and put them a number of times. So you need to know that in between, how do you make sure that they don't get contaminated, and how do you make sure that these PPE, they don't lose also their integrity. Extended use is when you use PPE for longer, and CDC sometimes talk about you can extended use up to 4 hours, 4 to 6 hours without removing them. So we must also be careful about the issue of discomfort. CDC, they're also warning about that. So we need to know that as we optimize the supply, we also don't have to compromise the discomfort, because it is important that people also take breaks in between. So in terms of surgical masks, the information that I have here currently, WHO is saying that surgical masks should be available for patients with respiratory symptoms. And Tanusha also emphasized this concept that it's not recommended for asymptomatic individual. So, but as we're saying that the information is changing as the situation is evolving. So if there are any updates, I'm sure all of us will know and will update our communication accordingly. So in terms of respirators, then they are recommended for users who are in direct contact with the infection source, or those who are performing aerosol generating procedures. So those are the people who should be worried about fit testing, because if there are issues with respirators, which they don't know if they fit them, it may not be ideal to use them in a way that should be used, because the protection that is desired from those respirators may not be achieved. For the past few days, we've been hearing about disinfection of N95 respirators in general, in a way of also optimizing the supply. Validations of methods are ongoing. Some are failing techniques, some are techniques which are recommended. Those who managed to join in a webinar, I think it was really well marketed and communicated. I know also received it through our SIO communication. So those who managed to join, they spoke about different methods which can be used to disinfect or decontaminate respirators. So it's up to the organization, what is it that you can adopt into ensuring that you reuse your respirators after they have been disinfected. So, but as far as I know, I don't know of any workplace in our country as yet who have started to perform those techniques. So there's a question I also saw that it came through now. Someone wants to know what is the difference between a mask and a respirator. Yes, a mask by its own definition is a surgical mask. Under SANS, they refer to it as a medical mask. So surgical mask and medical mask is the same thing. Then a respirator, you get, we often call respirator a mask. I don't know where the concept is coming from, but now if you want to talk specific, because when you do a risk assessment, you need to give a specific recommendation. Who should wear a mask, who should wear a respirator? Hence, it's important to use the right weights. So a respirator for COVID, we are talking about FFP2 and N95 filtering face piece respirator. So those are the two differences. And their functions are different because when you wear a surgical mask, it means you are symptomatic, then you are worried about the person who's gonna be exposed to you. But when you wear a respirator, you are likely to be protected from the source of infection, and you are also preventing exposure to others. So it works in two ways, and the surgical mask work one way only. So in a normal situation, we're going to talk about if you use respirator, you must have an effective respiratory protection program, which include policies that is supported by management, buy-in by employees, respirator selection, medical evaluation training, and respirator fit testing. So as I have mentioned that respirator fit testing, the reason I have been asked is because it has been confused with other concepts. So I will try to clarify. So respirator fit testing cannot be replaced by a SIL check. SIL check is what you do every time when you put on your respirator to make sure that it's sitting properly. So a fit test is a test, a specific test that it is done to really confirm if a specific type or model or size of a respirator can fit you as an individual, not a group of people. So if you do this fit testing, you cannot do one person and you offer the same size or style to a group of people. It's an individual test. Sometimes people are confusing fit testing with filtration efficiency testing. So filtration efficiency testing is what I spoke about, that FFP2 and N95 are equivalent because FFP2 filters at least 94% of the particles and N95 filters at least 95% of the particles. Hence, they're saying that they are equivalent. They are not the same, but they are equivalent. So by doing fit testing, you also giving employees confidence that they are protected by their supplied respirator. And again, in this situation where physical, where practical, and if resources are allowed, because there's a new hazard now, so you may need to confirm, especially for those people who are required to wear a respirator. So these are the two methods which can be used. But the point that I want to emphasize now that with the stock shortage, then CDC, from the information that I saw, they said that qualitative fit testing, it can be the one recommended during this situation because it will sort of minimize the destruction of respirators used during the process, as opposed to the quantitative one, which it really requires us to probe a hole during the process of testing. So in other words, when you fit test 100 people using a quantitative respirator fit testing, you will have to discard those 100 respirators. So we don't have stock. So if you like to do fit testing and you don't have those kind of resources, it is advisable maybe to look at qualitative, and or in the absence of both, maybe you can look at the control that the suggestion that I gave you. But that does not mean it replaces fit testing. We need to also know the factors that affect fit. Then when you have facial hair, if you have beard, then there is no guarantee that that respirator will fit you. especially with the beard, we can confirm that it won't fit you. If you don't wear the respirator properly, it won't fit you. It will fit you during the test, but if you wear it the way Onega showed incorrectly, the chances are you are walking around with a false protection. There are people even now, they don't know if there are different sizes. As far as I know, N95, with the models that I'm aware of, not knowing with the new products, I know they come in 2 sizes. Let's try to familiarize ourselves that based on our face sizes, we choose the correct type which is in line with your facial characteristics and your face size. And we also need to be careful that when we wear a respirator, it's compatible with other equipment, for example, the safety goggles. And the concept of multiple donning and doffing, please pay attention that if you start feeling that the respirator size and type is starting to lose its integrity, it does not feel like it's sealing around your face. Whether you use it for a few hours under the conditions where it's hot and humid, that can happen quick. So you may need to replace. It's not because it doesn't fit you anymore, it's because now it has lost its integrity because it has been affected by the environmental condition. So I just want to end up by saying some few limitations in terms of PPE in general. We know that in terms of COVID, when we wear PPE, the hazard still exists. That's why it's very important that we are working around it, yet it has not been removed in a workplace where we are. So, and using PPE dependent on users' behavior. I think one of my colleagues mentioned that it's very challenging to work around the person because it takes a lot of training, attitude, and so forth. So it's very much important that those who are expected to use PPE, they cooperate, they know the limitation that if they don't work hand in hand with the PPE, they may not be protected. And we must be aware that there's no one equipment to protect against every source of infection. So in other words, you cannot wear gloves and you want to protect exposure through your mouth and nose and your eyes. So it means you will wear different kinds because there are different routes of transmission. So you should use them properly. And if you use different kinds, you must be aware that it may restrict movement. And those who are wearing gloves and you're working with some delicate tasks, your dexterity may be affected. Those wearing safety goggles, your field of vision, communication and comfort is also important to be taken into consideration. And if you have to reuse, and you have to restore, and you have to do multiple donning, you must properly maintain your PPE. For example, if you wear gloves for long and now you touch contaminated surfaces, it means you'll be walking with your virus the whole day. So the risk assessment will maintain what is it that you need to wear longer and how do you maintain to make sure that your PPE do not become sources of infection. Regular training is very important. We may think for the past 3 weeks now we know what is it that we have been trained about, but we need to emphasize that people forget, people are stressed, people are running around, and people are helping where they can, and there's no time for training, but people need to be sensitized that whatever control that is available, it needs to be used properly. So in conclusion, I would like to say that improper use of PPE may result in false protection. So exposure will still exist even if you're wearing the correct type for the hazard. So let us be aware of that whoever is supposed or expected to use respirators or other PPE should use them properly. Thank you very much. These are the information sources that you can get more information, and you can also contact us at info@nioh.ac.za. Thank you.
Thank you very much. That was Juliet Mangani, dealing with PPE use and the respirator fit testing. As you noticed, there was quite a lot of very vital information in there, particularly for our frontline workers. whilst my colleagues are going to set up for the very practical demonstration of donning and doffing of gloves, putting on and taking off of the protective PPE gloves, I'm going to remind you that at the bottom of your screen is a chat box bubble. In that chat box bubble, for all of those who perhaps logged on a bit later or joined us along the way, we have reached, I think, 550 odd logging participants. Please add your title, name, surname, email address, and cell phone number. We will appreciate that. And that very same chat box is where you've got to include your questions that our presenters will answer for our joint question and answer session at the end. So I hand over and welcome my colleague Taban Duba, who's going to demonstrate the donning and doffing of gloves. Welcome.
Thank you, Ashraf. I will be taking you on the doffing and the donning of gloves and respirators. So firstly, I will start with the gloves. So in this case, I will be using the nighttime disposable gloves. So before you wear your gloves, remember it is important to make sure that your hands are clean. So in this case, I will use the hand sanitizer to disinfect to clean my hands. And then after that, before I even touch any of my PPE. So the other important things before you wear your gloves is to make sure that your hands, you don't have any germs, because those ones, they can interfere and they can also cause some tears on the gloves. So since my hands are clean now, I'll start by donning the gloves. So also on the gloves, also there's different sizes, and it will also depend on the size of your hand. So in this case, you select the correct size based on the size on your hand. So I will start by donning. So when wearing the gloves, you make sure that you insert the first glove, and then you pull the tip of the glove to cover the wrist area. It's covered. And then you take the second glove. It's the same sequence. And then you wear it. And make sure you pull the tip to cover the wrist area. In this way, my gloves are well. And then also you have to check any visible tears so that you don't become infected with anything, whatever you are working with. So in this case, my gloves are worn correctly. So now I'll come to the doffing of the gloves. So for the doffing of the gloves are now contaminated. So the aim here is to make sure that you do not touch the contaminated areas of the gloves with bare hands, because in that way you will be defeating the aim of wearing the glove in terms of protecting your hands. So in this case, I have two methods that I'm going to demonstrate for doffing. So this one is the one that is recommended by the World Health Organization. So when doffing, you make sure what you do, you pinch the gloves at the wrist level, and making sure that you're not touching your hand. And then what you do, you peel it away, not touching, and to turn it inside out. And then after that, you use the gloved hands to contain the other gloves. And then after that, what you do, you slide your finger between the wrist and the gloves, not touching the surface which is contaminated. And what you do, you peel it away to cover the glove inside and out and to engulf the first glove. And then from there, you throw them into the bin. So that was the first method. So now I'm going to demonstrate the second method. In terms of donning, is the same procedure that I used. So this method for doffing, we call it the picking method. So I'm still going to wear the glove the same way, Nothing has changed. Same sequence. Adjust, and then check any visible tears, and then now come to the doffing for the picking method. So with the picking method, what you do also, you pinch the glove right near the wrist area, and then you peel it, and then you form what you call a bead. So if you can check now, the contaminated area is now covered. So now you have your clean area. So what you do, you use this area, which is the bead, and then you pinch it, and then to avoid touching your skin, and then you peel it away, and then throw it into the biohazard box. And then from there, you use your hand to just remove it, and then you use your finger, and then that's it. We are done. And then now I'm going for the respirators. So with the respirator also, you make sure that you disinfect your hands before you touch the box, because you do not want to contaminate the PPE. So we have two different types of respirators here. So I'm going to start with the V-Flex one. So you simply remove the respirator from the box. And then for this one, what you do, you put all the fingers of both hands onto the nose piece, and then you make sure that the thumbs are underneath. So gently you bend in the middle of the nose piece. And then after bending, what you do, you unfold the respirator by pulling the bottom part downwards and pulling the top part, which has the nose piece, upwards. And then you make sure the straps are on the top level. And then what you do now, you use one hand, you place the respirator on your face, and then the top part must be, with the nose piece, must be on the bridge of your nose, and then the bottom part to cover your chin. So with one hand, you pull the first strap below your ears, and then you pull the second one on top of your head, just above the ears, and then you check if the straps are aligned well. And then what's next? You can use these tabs to adjust for proper fit. And then after that, you use the fingers for both hands to adjust the nose piece. You start from the bottom, going downwards, and then when it's adjusted, the next step, you perform what we call a seal check. So with the seal check, you put both hands onto the respirator, and then you exhale out sharply. In that way, if you feel any air coming out, if it's on the top of the nose piece, what you do, you readjust the nose piece, and if it's anywhere on the respirator except on the nose piece, you can use the tabs or you can adjust the straps. And then after that, you do the seal check again to verify. So if everything is okay, you are good to go now. So now coming to the doffing. For doffing of the V-Flex respirator, so now the respirator area, the front area, is now contaminated. So your aim is not to touch the contaminated area. So what you do, you slide your finger, and then remove the first strap, and hold it, and use another finger to pull the second strap. Avoid touching the respirator which is contaminated, and throw it into the biohazard. and that's it for the V-flex. So now coming to the N95 respirator, which is the easiest one to don. So with the N95 respirator, you have, assuming you have disinfected your hands. So what you do with this one, you place it onto the palm of your hands, and then you allow the straps to hang, and then you place it on your face with the top part, which has the nosepiece, on the bridge of your nose, and then the bottom part to cover your chin. So from there, you pull the top strap and place it above the ears, and then you pull the second strap and place it below your ears, and then you come and then adjust from the nosepiece, starting from the bottom using both fingers, going down, and then after that you perform a seal check by examining sharply. In this case also, if you feel the air coming out on the top, you readjust the nose piece. And then if there's any other area also, you can readjust using your straps. And then you perform the seal check again to verify. So in this case, you are good to go to perform your duties. So after that, now we come to the doffing. The doffing, you also avoid touching the contaminated areas, which is the surface, the front surface of the mask. So what you do, you slide the fingers, pull the first strap, hold it, and then you pull the second strap to avoid touching the surface of the mask, and then you throw it into the biohazard bin. And then after that, you come and disinfect your hands, and then that's it. Thank you.
So thank you very much. That was a very detailed demonstration for us on the question of how the hand PPE as well as the respirator PPE, as my colleague Jeanette had reminded us that it's not a mask, it's a respirator, is in fact properly put on and properly taken off, properly doffed and properly donned. And I thank for that demonstration my colleague from the microbiology and immunology section, immunology and microbiology section, that is the Tuba. The next section that we will deal with now is the BioRisk Assessment tool. Ms. Monica Matuka is going to deal with that BioRisk Assessment tool. I think it's a critical tool for us to use in that, in this case, we're not dealing with the other categories of hazards that we face in the workplace. We are particularly looking at the biological hazards. And COVID-19 is presenting a significant new biological hazard we have to consider in our risk assessments that's now required for the purpose of this particular session, the BioRisk Assessment for frontline workers. Also, just a quick reminder again, please just add your title, name, surname, as well as contact details. We would like your email addresses and we would like your cell phone numbers in the chat box so that you can, that's at the bottom of your screen, so that we can have a record of those who have attended this particular session. I'm just going to ask my colleague Glenn if he could get the next presentation ready for us on the BioRisk Assessment tool. And then a reminder, any questions that you have that we'll cover in the question and answer session towards the end, please type that also in our chat box at the bottom. Our colleague Simpiwe from Information Services section is busy capturing that for us for our question and answer session. And so at this point, I'm going to ask Annika to join us while Glenn prepares the presentation for the session. Thank you, Annika.
Thanks, Ashok. So we're going to continue with BioRisk assessment tools. Which one can you use for doing BioRisk assessment? So just to mention that we are only guiding you on how to do a risk assessment. Like I've mentioned, the tools will differ. This is just a guideline or that you can use to apply in doing your risk assessment. So how to assess hazards and risks? As mentioned in the previous slides, the first pillar or the first step is to identify your risks. So then the focus should be on your source of exposure. So in this case, the agent will be the coronavirus. I've mentioned on the previous talk that the virus hasn't been classified yet, but it fits in the definition of a class 4 in the hazardous biological agent regulation. However, since this virus is evolving and there's many investigations that are ongoing, the recommendation now is to classify it as a class 3. So until we get a directive either from WHO or from the Department of Employment and Labor, we'll stick to a class 3 and not a class 4. I was just explaining that it fits in the definition of class 4. So while at that, you look at the agent. So that will be, for example, your laboratory workers will know exactly what they are using for manipulation in the lab or using them as a control. However, for other workplaces, you will focus on the possible sources which can expose you to the virus, which are mainly your body fluids or the person, for example, in healthcare workers, in prisons, in retail stores, you're dealing with people that can be potentially contaminated. Or your waste workers, the waste that they handle can also be contaminated. Or any other worker that's using an equipment in their workplace that can be contaminated with the virus, that can also be a source. So look at your environment, see what are the other possible sources, as I'm only listing examples there. Then you will list them in your potential source of exposure in your workplace. Then you look at the transmission pathway. We know by now that the transmission route is a droplet transmission or contact with contaminated surface or contact with an infectious person. So you put on there the mode of transmission is by direct contact. Although there's research that has mentioned the possibility of airborne transmission, there is not enough evidence. And like I've said, we will stick to what we are being guided at the moment. So currently, it's contact only. Until there's enough evidence and we got a directive that airborne is also a possibility, then we'll have to relook at our risk assessment and then add on that other transmission. But for now, it's contact. Then you move on, you look at who may be exposed to this virus. You look at the frequency of, it's for example, your worker. You look at the worker shift, how long they spend time in the workplace. With biological agents, I've mentioned there's no occupational exposure limits. But it has been proven that the longer you work or the longer hours you work, the more risk, unlike with shorter periods. So you look at the time interval of each individual. You look also at risk factors, as also mentioned in my initial talk. People who are immunocompromised. Do you have diabetics at work? Do you have people with high blood pressure, with heart disease? Take that into consideration as well. Then risk occupation. The focus is on the tasks at hand. They may be having the same job title, but their activities may differ. So you're going to split it further. If you're going to say, for example, the cleaner or security, for example, you may have a security that sits, for example, in a hospital ward by the passage, or you'll have the one that sits outside at the gate, only allowing cars to come in. So the exposure profile of those two different securities will differ. So that must be taken into consideration. At the end of this talk, I'm going to just show you scenarios of those different profiles within the same job title. So then you move on to the environment. In your environment, which equipment or tools or surfaces can be potentially contaminated based on the work area and where the people frequent. So you list that as well. And then semi-direct exposure will be the contaminated hands. So the workers at all times, as recommended, they must make sure they do wash their hands as frequent as possible, especially when they have touched contaminated surfaces. For healthcare workers, if you are dealing with patients, make sure you wash your hands before you do a clean procedure or even after touching a potentially infected person or the surfaces around your area. The surfaces and instrument that will be your indirect exposure. Just to know that risk assessment must be done with by a multidisciplinary team. The reason for this is that you will need different expertise to conduct risk assessment. As for example, a microbiologist will be focusing on the microbiology part, and then you're going to need a person who will look at the building as well. So you might need an engineer or an architect. You will also need an occupational hygienist as well in the field. So all these people has got different expertise. So bringing together that information will make it better, because you won't be able to like miss something between your risk assessment, which is one of the errors or limitations when people do risk assessment. To be only one person with limited information or knowledge, then they might be missing out some important information. So after recording all this, you keep your records for 40 years as recommended by the HPA regulation, and ensure that whatever is put on the tool or is recorded on your risk assessment report must be implemented. Remember, I mentioned that after identifying, you'll identify the control measures that you have in place in order to mitigate for the risk of exposure. But then, if there is something lacking with what you have currently, you may need to add on to what you have identified, and then you'll have to have an action plan. Whoever is responsible within your work environment, either it can be an IPC person, infection prevention and control, or your health and safety, or even your supervisor or manager, whoever is responsible for that role, whatever it will be, must be responsible for making sure that it's implemented, and the deadlines must be set so that we can move on and progress, because we don't want to be dragging to put on mitigation or controls in place, because we want to protect the worker at the time of work. So, and then the document or the risk assessment must be reviewed in between to check for progress as mentioned, and also to ensure that we are up to date. If there is any other change, if you bring in a new instrument, like for example now the NHS have launched the mobile clinics, the risk assessment has to be done for those mobile clinics, because it's a different setup from the actual lab that was doing the test. And then this report needs to be updated on a regular basis. So the tools are the first step of risk assessment, and then to identify hazards and to see what potential preventive measures can be put in place. So expert advice may be needed for complex risk, as I've mentioned previously. So it's not a one-size-fits-all, as mentioned by the previous speaker. It's effective only when adapted for a particular sector, as all our risks and hazards will differ. So you must do the one that is tailor-made for your workplace. There is no prescribed method, as long as you ensure that you put all important elements which has been mentioned on the previous slide on your risk assessment tool. Unless there's also other extra information that you may need for your setting, then you can just add on to the checklist. So it must be organization specific. So currently, the Compensation for Occupational Injuries and Disease Act number 30 of 1993 have classified risk groups by occupation. So the very high risk are healthcare workers and laboratory workers. But it's for those that does the procedures with aerosol generation, those that are handling samples of COVID-19 or handling suspected or unknown samples or treating unknown patients. So the second category is high risk. Those are your healthcare still, together with support personnel. But this group now, they are not doing procedures of aerosol generation, but they are entering wards where they can be infectious patients, the porters who are transporting in the healthcare, ambulance staff that drives patients to different hospitals, as well as mortuary staff that does the burial or even the cremation. Then you get the medium risk. Those are mostly where you get a high volume settings. Those are high volume settings, or where you get like congregated settings. So examples are your schools, your labor centers, like your home affairs, your police stations, your prisons. So where there's consulting rooms, or even retail, where people go and buy their groceries because there's too many people that come in those areas. So I'm just making examples of those. There may be other settings which are not included in this, but based on the definition of what is very high, what is high, and what is medium, will fit in your category in those categories, your group in those categories. If you're not sure, you may contact the COIDA and the Compensation Commission to get more clarity. And then you get the low risk. Those are people who have no contact within 2 meters with known infectious people or even the COVID-19 suspect. So in this category, there is minimal occupational contact, either with co-workers or the general public. So while keeping these 4 categories in mind, I'm going to go through the tool using one example for each category so that we can look at what health effects and what is where do they fit. So this is basically just the hierarchy of controls and examples of what you can do as control measures in your workplace. I'm not going to go through this whole list, but it lists all possibilities that you can apply in your workplace to fit within your mitigation strategies. But taking into consideration that you should follow all steps of the hierarchy of control, from elimination to administrative control, environmental or engineering, PPE or behavior. So this is just an example of a very high-risk group. Here we took example of a healthcare. So here is sample collection in a case where an occupational health nurse has to be collecting samples. So that will be the person that will be affected. And then for patient care, it will again be doctors and nurses. The hazard will be the same. As we all know, we're dealing with the coronavirus now. The route will be the same because of the transmission that is currently being proven. And then the health effects will also be the same, depending on which symptom the person is presenting with. So what you look at here is just examples. If you have this, the baseline controls will be what you have currently. If you currently have this, you are okay, then you just record what you have, and then residual controls will be what you think you should be having, but you're lacking. So if you don't have a procedure in place, then think about putting an SOP or a policy in place, and then flu vaccine we know is being recommended for all high-risk group in order to minimize health effects. And then the mask for infectious patients in the healthcare setting, if you don't have that at the moment, that's something to look at, and risk assessment as well. So it's just an example to say, oh, I have this in place, baseline controls, but I'm lacking this. So based on your risk assessment, you will determine what you're lacking, what you're having. Then you will put an action plan in place to say, we have to look at this and who should be doing it and at what deadline. Then in the same setting, you have a cleaner who's in a hospital cleaning the isolation ward. What is the difference between a cleaner in an isolation ward and a normal, ordinary cleaner in the office? So their exposure profile will differ. When you're doing risk assessment on that, take that into consideration. So you wouldn't take all these control measures of providing gloves, flu vaccine, or putting a procedure. Some will be like overlap, they will be for both, but some will be specific based on the risk profile. So you'll ask yourself, do I need a respirator for this one? Because the person is working in an isolation ward, and then there may be a hospitalization procedure taking place in there possibly, so they may need a respirator. But if there isn't any hospitalization, then they may not need a respirator. So we go into retail work. Retail work is also broad. So you have to look at the job task as mentioned, because in a retail or a shop, you'll find a cashier there, you'll find a packer, clerks, and salespeople. So their exposure will differ as well, therefore the risk will be different. For example here, because clerks deals with pen and papers, that can be the source of exposure. As mentioned, paper can harbor the virus for a few days. The cashier can be exposed at the pay point because they use a speed point, for example. Different people or customers are pressing their pins there, so there's potential contamination for both the public, even the cashier. So the cards, exchange of cards also for swiping can be a source of exposure, for example. Then for your salesperson, for example, hangers, as they are hanging clothes and moving clothes, customers are also touching the hangers, and you don't know whether they're contaminated or not. So looking at that, also you look at what you have. But of importance there, do you think the retailer needs a hand wash basin? Wherever they are working, is it accessible? It's something to think about. If not, then provide them with a hand sanitizer. So residual controls also can be some new things to look at in order to mitigate strategies, to mitigate exposure. I've seen one example, I think yesterday or day before yesterday, where Pick n Pay is now introducing perspex screens on their tellers in order to form the barrier between the customer and the worker. So those are things to look at. Look at cashless payments. Can we do that instead of cash, which is likely to be highly contaminated, rather go for the cards? And with cards also, at least you'll have a sanitizer to use in between exchange of cards. Then we look at safety and security. These are your medium risk groups now, based on the definition by the Quaida Act. So you look at your securities, do they need hand wash? As shown in the previous slide, that worker that is on the road doing checks, there's no access to water basin there. So you may want to provide them with sanitizers. We've discussed that last issue as potential source of contamination as they'll be reusing the gloves. Or is there a possibility maybe of letting them not touching any permits or license? Let the driver show it to you, or have something like a tool where they can clip it on, then you look at it and give it back without touching the paper. If they are at close range with the driver, do they need a respirator? Or can we find another way of just sticking to the 1 meter distance maybe to avoid exposure? So those are things to look at or to consider when putting controls. Then your low risk gardening, for example, they just went outside, it's open, enough ventilation, natural ventilation, there's enough sunlight there. Do they really need respirators? I do not think so, but they need to be trained, because even in the yard or the workplace, they'll be coming into contact with their co-workers when having lunch, when probably just chatting. So they need to be educated to know that they are risk, so that they can protect themselves as well. So these are just examples that I was mentioning, that you can have securities, but they may be doing different jobs. So security at the booth, they have some sort of an engineering control. They have a window here. There is some distance that's been kept between the visitor and the security. But there is a registration there and a pen that is used by everyone. Think about that to avoid transmission from one person to another. And you can see here, there's 2 of them. Also consider controls to put into place, educate them so that they know the distance they must keep and what practices they should do. Have some kind of posters or awareness there to educate the visitors, as well as our security also, so that they know their hazards and risks. There's a few control exposures that you can look at, but mostly it's everything that you have mentioned that is common for everyone, like your policies, your hand sanitation, your disinfection. You need to have chemicals or disinfectants also to clean surfaces. So you may want to provide also to your securities for cleaning their environment. So the security at Bungate, also in a booth, but they are not coming in and out. So they just look at the car, they open, the car comes in. But what if the boom is malfunctioning? They may have to come out to come and do manual recording. So that could be also a source of exposure, because now it involves the pens, it involves the paper, and then also if they are changing shifts or they're working together, they may be sharing a remote control to open the key. So that's something also to take into consideration. You have a security at the counter, like in airports, for example. Those are at very close contact with the travelers or their customers. So consider what control measures, what could be the risk factor. The traveler may be sneezing there, so you may want, based on your risk assessment again, you will know, discuss with your workers. If there has been people who've been sneezing and coughing, they will let you know they might need a respirator there to protect themselves. But if there is no need, there isn't. But you would think that there's high density there. So you wouldn't know who's infected and who is not. So based on your risk assessment, also consider that as well. And then those that search people as they come in, there's close contact there. Some are even touching manually. At least this one has got some measure in place to touch, but this also needs to be decontaminated. So securities at the mining industry, for example, who has to allow the workers to come in and do a breathalyzer test before they enter the workplace for their safety also. So the worker is required to blow onto this machine. Blowing means you are releasing the droplet from there. So as you can see from here, they have some kind of control in place. They have wipes to wipe after each individual has blown there. But the concern here is that they will probably be queuing here at a close distance of each other. So they may need to be trained to keep 1 meter distance, or there might be a temporary solution to keep them at a certain area, or let them come in one by one to get into here. So with your assessment, you know your workplace better, you are able to determine what measures you can put in place to avoid close contact, to avoid transfer or cross-contamination. You get your cleaners in the public areas, in your malls, in your airports, or even other big areas, call centers and so on. So here now, they're coming to contact with the surface also that may be potentially contaminated. So the question here is that, should you be providing them with a respirator? Dealing with the public that you don't know their status, maybe that's something to think about, to provide for the worker there. And the gloves is a must because they will be disinfecting or cleaning the surfaces. They may be using reusable gloves, which also needs to be disinfected after use and dried out, so that to avoid a contamination also. Then you get your cleaners in the office. Do they really need a respirator? We know if an employee is going to be sick, they will quickly be identified and detected, so they shouldn't even be coming to work. So I don't think a worker there, a cleaner, they will need a respirator, because we have to target to break the chain of infection at the source, as mentioned previously. So the first step here that will help is to detect early and then isolate the person. So you have those cleaners, as mentioned in the previous slide, on the tool. The cleaner may be working in an isolation ward or where there's aerosolization that's taking place. So you may want to provide a respirator to that worker because they are classified as high risk due to the aerosol generation processes. So general recommendation is we must try hard to intensify awareness campaigns, especially with the new information coming in. People need to be informed and to know of the new developments with regards to coronavirus, and try to restrict movements in workplaces. It's fortunately now because of lockdown, most people are working from home, so there isn't influx of people coming into workplaces. And the correct use of PPE is important because we've seen and we are seeing everywhere. People are wearing respirators everywhere. They are not wearing them properly. They are using PPE where it's not needed. So do your risk assessment, determine who should be provided with PPE and who shouldn't. And let's give support care for the infected employee, because also, you know, it affects everyone and they are our employees. We need to look after them. And the staff must be encouraged to disclose travel history, as travel has been identified as a risk factor of transmission. And inform co-workers of possible exposure. If there's been anyone in the work environment that has been tested positive, alert the others, but keeping confidentiality, so that they just need to know of their potential hazards and risk in order to protect themselves. I don't mention names of who's affected or not. And then prioritize high-risk areas first after doing risk assessment, because those need more attention than any other. But we're not saying neglect the others. First prioritize high risk. So lastly, in conclusion, please do not forget to wash your hands. Thank you.
Thank you very much, Annika. That's Ms. Annika Matuka. dealing with the BioRisk Assessment tool. We dealt with that presentation first because we realized that this particular session is pretty jam-packed with lots of information, and we liked it slightly over time. We are going to share with you two very, very short videos, question of very few minutes, on hand washing and hand sanitizing. My colleague Glenn is just preparing that for you to see. So the first one I think is on hand washing, Glenn. Okay, so please watch this one. Glenn is just quickly unmuting me whilst we're waiting for the next video to be prepared. Just a quick announcement. We do have a problem with our time. We are going to be short. We'll show you the short video. And we've decided not to engage with the question and answer session for today because we are over time. And we will definitely answer all of your questions that you've typed for us in the chat bubble. We will answer that for you and reply to you via your email addresses, and we normally include all of these questions and answers in our FAQs, our frequently asked questions, and it will be online on our website. Thank you, Glenn. Okay, so thank you, Glenn, for that. If we could just get the Thank you. Okay. So that brings our session today, that is the National Institute for Occupational Health, NIOH's COVID-19 training session to an end on the BioRisk Assessment for frontline workers. I'm just quickly going to invite my colleague, Dr. Tanusha Singh, just to make some concluding remarks. Thank you.
I've noticed that many people have been requesting CPD points. We have not registered with CPD points for the Medical and Dental Association, but we will engage with them. But it's important that if you require CPD points, you register your name and provide your Health Professional Council number so that we can retrospectively allocate the points for you. Thanks.
Thank you very much. I think that's a very important point to touch on and announce. It's been a request also in the GPs, general practitioners and dentists session that we did 2 days ago. So just to end off, thanks, yes Glenn, that's a slide. This is critical to share with you. This is also available online. It's also, I'm not sure it's part of the actual videos or slide on its own on our website, but I'll check on that. Is the list of key websites for you to use as resources, keeping in mind you are now dealing with essential services workers categorized for the purpose of the lockdown, and you are addressing their needs as frontline workers, but you're also preparing for the return to work phase. And if there are any other similar environments or situations where we might have people self-isolating on quarantine, we need to be prepared for that. And the website you see on our slide is from the National Institute for Occupational Health, the NIH website, the NICD, the NHLS, the Department of Health national website, the Department of Labor, and the World Health Organization. The Center for Disease Prevention and Control, the CDC, is also useful, keeping in mind it is particularly maybe for the context in North America, and we need to consider how we apply it in our own context, given our resource constraints we face. Then there's the ILO, as you see, there's 4 hotlines. The one hotline is the Occupational Health Practitioner hotline, and I think that's a critical one. It's just recently also been activated. It's run through the NICD, sorry, that's the NIH one, the first one, and the 2 NICD ones are the public hotline and the healthcare workers hotline. The numbers are there, including a WhatsApp service that the National Department of Health is offering. You just type in hi, send it to that particular number on your WhatsApp, and then it'll give you a menu of information that you can type in the menu words. And then finally, a reminder, for any other questions you have for us, please send that to info@nioh.ac.za. That's info@nioh.ac.za. And we thank you for joining us today. I would like to thank all of our presenters, Dr. Tanusha Singh, Ms. Anika Matuka, Ms. Jeanette Mangani, my colleague Taban Duba, and our colleagues behind the scene that you don't see. That's Glenn and Simpi. We're working very hard behind on the other side of the camera. Thank you, and we hope to see you soon on another Zoom session, which I see in some of your comments you've indicated you hope this will continue. Goodbye.